This is our second section of hematology, looking at the other hemolytic anemias. Cold agglutinin disease is IgM disease. The main issue is it doesn't get cured with steroids. G6PD deficiency is a result in oxidant stress, and hemolytic uremic syndrome and TTP are a spectrum of the same disease. PNH is paroxysmal nocturnal hemoglobinuria, and despite it being a very unusual disease, is very usual on step 2. Cold agglutinin disease, well, what's the difference between that and cryoglobulins? Well, cold agglutinin disease is exclusively a cause of hemolysis, and cryoglobulins causes renal failure. That's one of the most frequently incorrectly answered questions on the whole test. They are both IgM diseases. Neither of them is routinely treated with steroids. But the difference is cold agglutinins is basically an anti-red cell IgM. This is IgM antibodies against red cells, and it's in association with Epstein-Barr virus and Waldenstrom's macroglobulinemia and the infection of mycoplasma pneumonia. It presents with a person who's got symptoms in the colder parts of the body. And the colder parts of the body are the acral symptoms of the nose, the ears, the fingers, and the toes, simply low temperature. And the name is a great disease because it really just tells you, hey, in the cold, my red cells agglutinate. Isn't that interesting? And the symptoms resolve on warming the body part. The diagnosis is based on the fact that the IgM only makes a Coombs test positive for complement. Now, I know that might be difficult for some of you. You might say, well, I didn't know there's a different part of the Coombs test. Well, there is actually. There's a direct Coombs for IgG antibodies. That's also known as warm antibodies, autoimmune antibodies, IgG antibodies. And in cold agglutinin disease, the Coombs test is positive only for complement. The smear is going to be normal in almost all people, and that's because the hemolysis is occurring inside the spleen and often, much more often, inside the liver. That's why you can't treat it with splenectomy, because only a very tiny amount of the hemolysis occurs outside the liver. You may see spherocytes because the spherocyte's a sign of pieces of the red cell membrane being removed, and it turns it into a round shape. Because a biconcave disc needs lots of surface area, and if you remove that surface area by grabbing it out with an antibody, it becomes smaller, tighter, and rounder. They will almost certainly describe a person who's got mycoplasma pneumonia, but they won't say the word, they have mycoplasma pneumonia, because that at this point is almost a buzzword. They'll describe a person who's got bilateral infiltrates on a chest x-ray with a dry cough, and then say they're getting blue areas and mottling on their toes, their nose, their ears. I'll say, what is the most accurate test? The Coombs test. What's the best initial therapy? Warm you up. Rituximab is the treatment. Rituximab is a great drug. It removes the lymphocytes that makes the abnormal antibody. Rituximab doesn't get rid of the antibody. What it does is it gets rid of the lymphocyte that makes the antibody. That's why rituximab, here are the answers for rituximab. Rituximab is the answer for rheumatoid arthritis, for cold agglutinin disease, and for non-Hodgkin's lymphoma. It's also occasionally sometimes used in people with CLL. In addition, we can try and control that immune system with cyclophosphamide, cyclosporin, and other immunosuppressive agents. Basically, this is a different way of saying, hi, can you name me all the things that can remove antibody-producing cells? And that's why it looks an awful lot like a combination of the treatment of leukemia, lymphoma, and the treatment of organ transplant rejection, because cyclosporin is a calcineurin T cell inhibitor. Plasmapheresis is occasionally used in some patients, but it's very hard to remove an IgM with plasmapheresis. The bottom line on wrong answers, the most common wrong answers are steroids and splenectomy. Steroids and splenectomy just don't work for cold agglutinin disease. Cryoglobulins are often mixed up with cold agglutinins. Remember, they're both IgM. They don't respond to steroids. Cryoglobulins associated with hepatitis C and joint pain and glomerulonephritis. And cryoglobulins is not treated with steroids either, and it is mostly treated by treat the hepatitis C that caused it. Glucose 6-phosphate dehydrogenase deficiency is an X-linked recessive disorder. G6PD is necessary to generate glutathione reductase to protect red cells from oxidant stress. There's all sorts of stresses that come into the body. The infection is the most common one. So the most common cause of oxidant stress is not dapsone, the pneumocystis drug, quinidine, sulfa drugs, not primaquine, the malaria drug. It's for Vivax and Ovali malaria. Nitrofurantoin, which is a urinary tract antibiotic. Flavabines, no. G6PD mostly presents in infection in people who are deficient. And because G6PD deficiency is X-linked recessive, the manifestations are almost exclusively in males because it's just like hemophilia A, when meaning that women can carry it, but men express it. You will see the sudden onset of hemolysis in a male patient. When you see that sudden onset of hemolysis, you should look also for African American or Mediterranean males, and it's got to be sudden onset of anemia and jaundice because it's hemolysis, and the indirect bilirubin is causing jaundice. And there's a normal sized spleen because you need time to make a big spleen. Spleens don't grow over an afternoon, and it could be with infection or drugs in the history causing it. Unless you see that thing in the history, it's unlikely you're going to make the diagnosis. The best initial test for G6PD deficiency, well, it's not a level of G6PD because on the day of your hemolysis, the most deficient cells are destroyed. So on the day of your hemolysis, the best initial test, look at this, is bite cells, bite cells. See that taking a bite, taken out of them? Look for bite cells and Heinz bodies. Heinz bodies is oxidized, precipitated hemoglobin inside the red cell membrane. If it's in your bathroom, your basement, or your garage, we call that rust. But inside a person who's got hemolysis from G6PD, it is a person who's having oxidant stress. And those Heinz bodies are bitten out by somebody who's got a spleen that grabs them out. Now, that's what you can see on the day of your hemolysis. The most accurate test is the G6PD level, but not today, in 1 or 2 months after the acute onset of hemolysis. On the day of your hemolysis, the G6PD level will look normal because it will be a person who's destroyed the most deficient cells. The most deficient cells will be destroyed. There is no specific therapy to reverse the oxidant stress of hemolysis. You can do nothing except just avoid the next episode, and nothing reverses it, just make sure it doesn't happen again. HUS and TTP are a spectrum of the same disease. HUS occurs in association with E. coli 015787. You're going to be asked, and you're going to know it. You're going to feel satisfied. It is more frequent in children. TTP has the same manifestations such as intravascular hemolysis, schistocytes, helmet cells, fragment cells, that is, hemolysis, low platelets, and renal insufficiency. But in addition, TTP will give a fever and is more common in adults. TTP is associated with cyclopidine, and that's part of what killed cyclopidine, which is TTP and neutropenia. Clopidogrel can do it too. And we don't know why cyclosporin and HIV are associated with it, but they are. The main difference between TTP and HUS is that it is associated more often with neurological disorders such as confusion and seizures and fever, and is more common in adults. However, I'd like to emphasize the smear is identical between both of them. The low platelets is identical, and the renal insufficiency is identical. The closest thing there is to a diagnostic test for HUS and TTP is the smear, the intravascular hemolysis with the fragmented cells. Look at the arrows pointing to these fragmented, broken up cells. It's like taking a plate or a glass and smashing it, really. And if I showed you the smear, you could not tell automatically that wasn't disseminated intravascular coagulation. But this is the closest thing to a specific test. There's certainly nothing specific about thrombocytopenia, and there's nothing specific about renal insufficiency. So if the question says, which of the following is the most specific test in the context of this patient, the closest thing is the fragmented cells. The big clue to it not being DIC is that DIC is predominantly characterized by the coagulopathy with a high PT and PTT and abnormal D dimers. But the major issue is the PT and PTT. In DIC, you've consumed clotting factors as well, and that's not happening with HUS and TTP. In HUS and TTP, the PT, PTT are normal. There is no one specific diagnostic test to diagnose either of these disorders. The PT and PTT are normal, and the other issue is a negative Coombs test. Now, that issue about a negative Coombs test is mostly at the beginning when you're evaluating for hemolysis, because autoimmune hemolysis has a positive Coombs test. Because the smear is normal in autoimmune hemolysis, the peripheral smear will not show fragmented cells. The positive smear absolutely excludes IgG-mediated warm antibodies. Now, the treatment in severe cases is with plasmapheresis or plasma exchange. And this is hard for people to understand. You're not taking off something. You're actually putting on a factor. You're putting on a factor that actually dissolves away von Willebrand's factor. It's a metalloproteinase called ADAMPS13. Look it up, ADAMPS13. Go to Wikipedia, become a 30-second expert. ADAMPS13 is what you're putting on, and it melts away the von Willebrand's factor and releases the platelets. See, if there's a delay to plasmapheresis, you can just infuse FFP. You might say, well, why not just do that? Why not just infuse FFP? Because plasmapheresis is rather like a dry cleaner. It's like a swimming pool, really, compared to your blood volume. Huge volume. Plasmapheresis uses huge volumes of plasma, not just putting on a few units. This is critically important. Ready? It's very important. Pay attention. Do not transfuse platelets into these patients with HUS or TTP. If you give them platelets, you're going to make it worse. This is a consumptive use of platelets. When you put platelets in, the platelet transfusion worsens the disease because you're creating the platelet strands in the blood vessels that cause the whole problem. Don't give platelets. Paroxysmal nocturnal hemoglobinuria, PNH, is a clonal stem cell defect. That means it's like a leukemia or aplastic anemia. One stem cell goes awry, and there's increased sensitivity to complement. Now, complement is what the immune system uses in complement, in addition to its other immune mechanisms to destroy invaders into the body. Now, the problem is it's abnormally destroying your red cells. It's get activated in acidosis, such as the relative acidosis that happens when you go to sleep and the respiratory rate goes down. When you sleep, respiratory rate down, CO2 up, pH goes down a little, and you and me doesn't do anything. But in people who have abnormal CD55 and 59, the decay accelerating factor, it destroys your cells. This is a deficiency of the complement regulating protein CD55 and 59, also known as the decay accelerating factor. We should also call it complement removing factor, which is what it does. It removes complement from cells before they can be destroyed. So if you're deficient in it, you don't remove the complement. The gene for phosphatidylinositol glycan, PIG-A, is defective because you see the decay accelerating factor anchors on PIG-A. PIG-A codes for the anchoring point. If you don't have PIG-A or you have a defective PIG-A gene, you can't anchor the CD55-59, you can't get rid of the complements. And during sleep, the relative hypoventilation leads to increased CO2, acidosis, and destruction of cells. It doesn't do anything to an ineffective person. Now, in PNH, besides the hemolysis, the question, what is the most common cause of death? Thrombosis. What is the most common cause of death? DVT, PE, and Budd-Chiari. Budd-Chiari is hepatic vein thrombosis. Because the hemolysis happens at night, the presentation is episodic dark urine. Now, that dark urine happens with the first urination of the day, and that's because the hemolysis is happening at night. So unless you get up to urinate in the middle of the night, that hemolysis should be with the first morning urination, dark urine. There's a pancytopenia, or at least two cell lines, and that's a big key to this diagnosis because there's more than just red cells. There's a pancytopenia, and iron deficiency anemia is from the chronic loss of iron in the urine. PNH is a stem cell defect. It causes aplastic anemia, myelodysplasia, and acute leukemia. And the most common cause of death is thrombosis. Look for that pancytopenia with PNH. The most accurate test is a decreased level of CD55 and 59. The Ham test and sucrose hemolysis tests are never the right answer. That's old stuff. You should never have been taught. And if you haven't been taught, don't learn it, because we only would even mention it here because this is a board review course. We're doing Step 2 CK. So we got to tell you what the wrong answers are. In regular medical school, I never tell people about this unless we're doing history class. But in Step 2 CK, our job is to make sure that when you go in there on test day, you're going to know what the wrong answers are too. The good news is, even if you forget the right answer, if you know that Ham and sucrose hemolysis are definitely wrong, you can still get the correct answer by knowing not to choose the wrong thing. Flow cytometry is another way of saying CD55 and 59, or cell sorting. The best initial therapy for PNH is prednisone, glucocorticoids. It does not cure the disorder. The only way to cure that disorder is an allogeneic bone marrow transplantation. Allogeneic means it's someone else's bone marrow going into you. Autologous means we take a sample of your own marrow and put it back into you. Eculizumab is an anti-complement 5 antibody. It inactivates C5, complement C5 in the complement pathway, and decreases red cell destruction. It is a complement inhibitor. Folic acid is used, like in anyone who's got chronic hemolysis, and iron replacement with a transfusion is sometimes needed as well. But any chronic hemolysis gets folic acid.